Thank you. My name is Alta Charo. I'm at the University of Wisconsin Law and Medical Schools, and as the chair of the Planning Committee, I would like to thank you for coming to this workshop on ethical review and oversight issues in research involving standard of care interventions. We're going to have a moment in a little while to introduce the members of the Planning Committee, but I'd like to introduce the more important people, and that would be the staff. Ann Claiborne, Chris DeFeo, Sheena Posey, and Christy Park. If you want to just wave your hands, let people acknowledge that you guys do all the real work here. Thank you. This meeting is being convened by the Institute of Medicine under the auspices of the Board on Health Sciences Policy. It is, however, a standalone workshop. That means it is not one of the consensus studies. It is a standalone workshop that is not part of some ongoing IOM activity. A brief summary of all the presentations you hear today and tomorrow will be made available sometime after the meeting, and also a reflection of some of the conversation that took place. That summary is going to be prepared in accordance with the IOM standard procedures and institutional policies. It will be published by the National Academy Press. It will be widely available as a resource. But what is being published will reflect the views of the speakers, and it will not reflect the views of the Institute of Medicine itself. Also, the workshop in brief will be made broadly available to the community. When I was preparing for the meeting, I was looking up various definitions of standard of care, and I noticed an interesting difference when you go across, and this was just a random selection of the many definitions you find. In the first one, it talks about a diagnostic and treatment process that a clinician should follow, which sounded like there is a single standard of care for every condition. But when you look at other definitions, they're much more open and talk simply about a treatment, and the implicit word would there be any treatment that's accepted by medical experts as proper. And that would certainly suggest that there are multiple standards of care, and I think that, of course, matches our experience as both physicians or patients. Question then, of course, becomes which standard of care is appropriate, under which circumstances, for which people, under the care of which kinds of physicians. So ideally what you'd have is evidence to give you an idea of which standards of care actually work best under which circumstances. Evidence, however, comes in many forms, and this is a slide that that reflects one version, and it comes, I forgot to put the site here, I think this was from the CDC, Preventive Trials Group, but it comes in various flavors of increasing rigor, starting with simply opinions based on personal experience from respected physicians or other kinds of authorities, all kinds of anecdotal evidence, and the kind of thing that we are all familiar with as a kind of accumulated community knowledge. But then you can move into things that are somewhat more formal with time series designs and cohort and case control studies. And then you get to formal clinical controlled trials. And the most rigorous usually are going to be those that involve a randomized controlled trial with some kind of proper control. Doesn't necessarily have to be placebo, of course, but some kind of proper control. Which leads us to the question of how we're going to do those studies if that's the best evidence. We need it because comparative effectiveness research is becoming more and more important and has become a central part of the government's program to implement the Affordable Care Act. So we need to have good trials and good evidence to inform our physicians and our payers about which of the treatments are going to be most effective. And of course, they can be looking at sort of meta-analyses of ongoing research in other settings, but there's going to be a need for new studies to answer questions that have never been properly tested before. So that is going to be the challenge. How do we conduct these studies that generate the new evidence? So when we construct the clinical trials, mostly it's going to be the same questions we're familiar with when we're doing investigational drugs or experimental surgeries or any other kind of new intervention. There's going to be questions about how you recruit people and how you describe the purpose of the research, how you describe to them what it means to be a research subject or research participant. You have to describe the methodology, which includes describing randomization, and give them information about the possible risks and benefits of participating in the research, along with things like the fact that often there's no compensation for injury or that you're always allowed to leave the study. This is standard. Question is there anything different, and if so, what is different? when we're doing standard of care research that tests two things that people might have already gotten or been offered if they were in a purely clinical setting. And so we have to ask, are the risks of participating in research that compares treatment options any different? And if so, how are they different from the risks of those treatment options when they're offered in a standard clinical setting? And for trials that have formal randomization, does the randomization in and of itself constitute some kind of risk separate from the risks of the individual treatments that people are getting that they will be hearing about in either a clinical or research setting? Whatever you decide about whether those things constitute independent risks, the next question is, how foreseeable are they? How do you measure them? And how do you describe them so that people feel properly informed before they enter these studies and properly informed when they leave these studies rather than leaving confused or feeling betrayed? Now, of course, the Office of Human Research Protections has now put out a guidance that is certainly going to be the reason why we're here, is to allow us to think about some of the same issues that are coming up in the guidance and for which there's an opportunity for comment. And we are going to shortly see a film that will give OHRP's Director Jerry Menikoff a chance to kind of explain what's going on in that guidance. It is, I want to emphasize, it is something that is largely triggered by the experience with the support study. But this meeting is not about the support study. There's been a lot written about it. Many people in this room have written about it. But this is not a meeting to relitigate the support study, but instead to look more generally at the entire range of standard of care research possibilities and to think broadly about how to go about doing it. So I was offered the suggestion earlier that we should hand out little bells to people, and anytime somebody said support, we should all ring a little bell to make you stop saying it. We don't have the bells, but if you will mentally please just ring the little bell. It'll help us make sure that we don't get bogged down in the details of that study or the particular personalities that have written about it from different perspectives. The general agenda, you've probably received this, but I just want to emphasize for you what it's going to be. We're going to start with this question of randomization, because that certainly seems to be one that is at the heart of some of these discussions. Next, we'll talk about methodologies for evaluating risk and deciding whether they're reasonably foreseeable. And then we'll talk about how we frame those risks and how we should give people information and formally incorporate it into the consent. So we're going to have this film now. Again, I want to emphasize, although the film will, of course, talk about support, this meeting goes beyond that. It's just to let you know what OHRP is putting out as a draft. I will come back afterwards. I will very briefly do some housekeeping as well as introduce members of the Planning Committee, and then we will start with our first panel. So thank you very much, and thank you again for coming today.
So, as I'm sure a lot of you now, about a week or so ago, OHRP released a draft guidance document addressing exactly this issue. It is out for public comment. There was a 60-day comment period. We are very eager to have as many people as possible comment. So I'm going to go through the thinking behind our guidance document. Not so much a lot of the technical aspects of it, but sort of the main themes. Before I do that, I know a lot of you know the background to us, but I do want to first address some of the background, particularly for those either in the audience or those on the web who don't know a lot about what was going on here. So there is a concept called standard care, and this is a legal concept. It's highly relevant to a lot of lawyers who practice in this area and also to a lot of people who provide health care, doctors, nurses, etc. And it's sort of a somewhat vague concept, as a lot of legal concepts are, but the bottom line is, let's imagine we have a particular disease out there, and the question is, our society is not going to allow doctors to do anything imaginable in terms of treating the disease. And so lines are divided. There are acceptable ways to treat the disease, and there are not acceptable ways to treat the disease. And in terms of the law, malpractice is sort of the line, the side of the line where the doctor is doing something that is outside the standard of care. For some diseases, there may be one very well understood way to treat a particular disease. And again, you would call that standard care for that disease. For a lot of medical conditions, there may not just be one acceptable way to treat that condition. And in general, it works out, well, are there enough doctors out there, a high enough percentage of doctors who think this is a particularly acceptable way to treat the disease? So there may be more than one version of standard of care for that medical problem. And it works out that for a lot of medical problems, there probably are more than one version of standard of care. You should also appreciate it isn't as if there's sort of, a book or a series of books that tell you these are the standards of care that you should follow. By and large, all the law I'm talking about here is on the state level. So each state has what we call tort law, and that determines when doctors are or not committing malpractice. And again, a lot of this consistent theme here is it's pretty vague, okay? It's not like you go to medical school and they hand you these things that tell you, here's the standard way to treat this disease and that disease and whatever it is. For a lot of things, you just discover it's pretty muddy, it's pretty vague. So the guidance we put out, as sort of the title says, is about what should be disclosed to subjects when you're enrolling them in a study. And there are various versions of this, but basically the simplest version, you're randomizing people between two possible treatments, and both of them are within some version of the standard of care. That's sort of the generic type that the guidance is addressed at. And why we're putting, or one of the major reasons we're putting this guidance out goes back to a particular study that OHRP had some compliance action relating to, and this is a study called Support. And I want to emphasize the guidance is prospectively looking. We're looking forward. I'm just giving you a little background about Support now, and in my slides I'll say a little bit about it. There's been a lot of dispute about many aspects about Support. It's gotten a lot of public attention and commentary, and certainly if you're interested in this issue, you may want to look into all of that. But I'm just indicating in terms of where we're going, we're looking forward. It's not so much at this point about what did or did not happen in Support, but some of it is just factually relevant in terms of giving you examples of in particular, what generated this debate. And to just give you the sort of two-sentence summary of Support, there's been concern for a long time about when an infant is very, very premature, they generally need oxygen supplementation. And the question is, if you give them too much oxygen, there's a risk they will develop a pretty serious eye problem called retinopathy of prematurity, and for some infants this can lead to blindness. There are ways to treat it, but the treatment isn't always fully effective, so it's certainly not a good thing. And so there's been probably pretty much general agreement on the notion that we were just not sure where exactly is the right oxygen. And it was understood that you could give, the way they do this, they put a little device called a pulse oximeter on a toe or a pinky, whatever it is, of the infant, and it could actually measure the oxygen saturation percentage in the infant's blood. And you'll see in terms of this debate, there was recognition that between 85% and 95% are levels of oxygen that one or another group of doctors viewed as acceptable and within the standard of care. And the goal of the Support study was to figure out, well, maybe we are, in general, putting a lot of infants at too high a level of oxygen, and maybe we get closer to 85, and by doing that, decrease the amount of retinopathy of prematurity that's being developed. So in the study, the infants were actually randomized to two sub-ranges of that 85 to 95 range. And again, the goal was, among other things, and I'll talk in the slides a little bit about the disputed stuff about the other things, but certainly the one thing I think people agree on was to figure out, could we get a better sense of how low we could go within that range and perhaps reduce the amount of retinopathy of prematurity that is occurring. So that's my little bit of background, and I'll say more about that stuff as I go on. Okay, some of you may remember this commercial that was on TV for quite a while. The guy sitting at the table with a bunch of little kids, and he talking about, well, is more better than less, or is big better than small, and bottom line, AT&T's push was, it's not complicated. And I think in terms of the core concepts that we're talking about here, it isn't actually all that complicated, and I'm going to try to demonstrate at least those core concepts, so at least people could appreciate what the underlying issues are, and then we could debate about what's the appropriate response in terms of those issues. So let's go back to one of our core ethical documents. The Nuremberg Code certainly is a basis for a lot of the current thinking. And this is a part of the first part of the Nuremberg Code, is the only provision that's actually several sentences long, and it's about informed consent, and this is an excerpt from that. And basically it's saying that, you know, in terms of getting informed consent, what you want to do is provide information that will enable a person to make an understanding and enlightened decision. And understanding and enlightened, I think, says a lot in terms of what are we getting at. Let's give people appropriate information that they presumably find useful to them to make a decision about something. And we'll talk about what the decision is. So let me expand on that in terms of one of the themes I want to emphasize, getting back to why it isn't all that complicated in one way of thinking about it, is getting back to core ethical concepts. Some have said that this type of study that we're talking about, randomizing people to different versions of standard of care, raised a whole host of brand new issues. And there's one way of thinking about it that actually there weren't actually that many new issues, that there are core concepts that we've actually understood a long time, that hundreds and thousands of studies that have been approved by IRBs always incorporated. And this is trying to sort of boil it down to sort of the core elements. And it includes, again, a number of the core elements that we were trying to be clear about in our draft guidance. So let me just read it and emphasize some of the points here. If a study involves possibly exposing a person to different non-minimal risks, we're talking about changing what happens to somebody. I'm going to emphasize this again. If by enrolling in a study, you're not changing what happens to somebody, you're just watching them, or whatever it is. That's not what we're talking about here. We're talking about we're exposing somebody, we're doing something to somebody that's different than what otherwise would have happened to them. We're going to expose them to non-minimal risks. That's ultimately our key. We're talking about non-minimal risks, okay, different from those to which they would have otherwise been exposed. Another point, risks that have already been identified. There's been some talk out there that the original issue that was raised in the support case related to OHRP got involved due to a complaint, and it made certain findings about the consent being inadequate in violation of the regulations. And that was all after the study was over, and some people said, well, we were saying this based on new information that came out of the study. And we just want to make it clear, that's not what the guidance is about, and we could debate what actually happened in support. But we're not talking about gotchas, and that's why we highlighted the regulation, that we're talking about risks that actually, at the outset of the study, you already have a specific risk that you've identified, that if you get treatment A versus treatment B, our concern that is that by getting treatment A, you may have more of bad event X happening. Okay, so we already know about it. Okay, it's not something that suddenly pops out at the end of the study and then you retroactively blame the researchers for not having thought of it. That's not what we're talking about at all. We're highlighting it. You already are aware of this risk, and in fact, you're seriously concerned enough about it that this is one of the major reasons why you're doing this study. If you're trying to come up with, again, core concepts that hopefully a lot of people will think are very relevant here. So if all this is true, you're changing what happens to a person, you're exposing to different risks. These are risks that we already know about and are concerned about. People should be told about these risks and allowed to decide if they want to be exposed to them. And again, as the title says, this is an old core concept. Nothing in this should actually be considered new in terms of how we think about informed consent and how we think about protecting subjects in research studies, and particularly in clinical trials. A sort of an important point here, most of this debate is about the unique aspects of these studies that involve randomizing people to two arms that are both standard of care. And if you actually look at what our guidance says, and particularly look at the core concept that I just gave you, you notice it didn't say anything about standard of care. And the concept is broad enough that it actually doesn't matter that much whether or not what you're randomizing somebody to is standard care or not standard care. And I'll flesh out why that should be the case. But bottom line is, You're asking somebody to be in a research study. You're changing what happens to them. You're exposing them to possibly different risks than they otherwise would have been exposed to had they not been in the research study. We should tell them about those risks. The fact that the risks they're being exposed to are in a version of standard of care, it shouldn't matter. This is the basic core element in terms of the Nuremberg Code and the common rule that it's their decision as to whether or not they want to be exposed to those risks. And then, again, that's the main theme here. We generally don't expose people to substantial risks for research purposes without their consent. Whether or not those risks come about because what you're going to do to them is a version of standard of care or not, it's ultimately for them to decide. Related point. It also doesn't matter, because this is another issue that's sort of been debated, whether those risks are experimental or not, well understood or not, or even something that people commonly agree to for their own purposes. Because that's some of the theme in terms of the debate about standard of care. Well, it's standard of care. Lots of people are already getting this. And to just give you an example, because I want to pick something far away from infants and babies dying and going blind or whatever it is, let's imagine there are researchers out there who study how people move. And they basically, put some sensors on the people, and they could be recorded by a camera or some other device, and you just have the people do something. And often what you may have them do is do a certain type of exercise. It may be an exercise that is very common, that lots of people regularly do this exercise for their own well-being. And let's assume the exercise has some risks, okay? Not trivial, not huge, but some risks. You may sprain an ankle, you may do some other bad thing to yourself, who knows? So if you did that sort of study, and let's assume you're recruiting people, you're asking them to undergo this exercise in your facility, and you put on the sensors, whatever it is, you would normally be expected to tell them about the risks of this, okay? The fact that these are not unheard of risks, in fact, they're well-known risks. Again, people every day are regularly exercising with exactly this type of exercise, but because in the research study you are asking the person to undergo these risks, you tell them about the risks. They have a right to know what the risks are and to decide whether or not they're okay with exposing themselves to those risks. Again, it's a pretty straightforward concept. Now, just to compare, if you found somebody who is already going to do that exercise today, then the risks due to the exercise are not risks of the research study. They were already going to do that. The only risks will be, again, what you're changing. If putting on the sensors created a risk or something, that would be the research risk. But so that's sort of the dividing line here. Now I'm going to give you a few assumptions, just because, again, I want to focus on the sort of the core scenarios that I think people have been having the most of the debate about. So this is re-emphasizing some of the concepts I already told you about, right? The following discussions about studies in which participation may change the treatment given to a patient and thus change the risks to which they're exposed. If we're not changing what happens to the person, like my example of the person who's exercising, if they're already going to do the exercise today and all you're asking to do is, I want to film you, I want to watch you, whatever it is, the risks due to doing the exercise are not research risks. They were not created by the researchers. The person was already going to do this. So what we're talking about here, the key thing, and this is emphasized in the draft guidance, it's about change. It's about, are the researchers asking the person to change what happens to themselves? And because of that change in what happens to them, is there going to be some change in risk? Those are the two core things we're talking about. And just, right, the flip side of this. If you're not changing the person's treatment, if they get exactly the treatment they otherwise would have gotten, then the risks of the treatment, even though they're in the study, do not become research risks. I'm aware there was some confusion out there that, while HRP was saying this, we want to make it crystal clear we are not saying this. If you don't change what happens to somebody, so you want to study a particular treatment for a disease, and you recruit a bunch of people who are already about to get that treatment. That they're getting the treatment is not creating any research risks. You're going to have to be doing something else to them that might create research risks. But that they're getting the treatment does not cause that to be a research risk. Another assumption, the discussion that follows is about studies in which there is concern that the risk differences between the two treatments may be more than minimal, and that we've already identified specific differences. So, and this is getting back to some of the grayer areas. There could be scenarios in which we're looking at two different versions of standard of care, and we're what we're studying in terms of possible risk differences between them are less than minimal risk differences, okay? Sort of work out what sort of studies we might be talking about. But I want this as an assumption now, so we'd be talking about the core thing, that the change we're talking about, the differences we're even hypothesizing, we're not sure about, but that we're hypothesizing between two versions of standard care are differences that are more than minimal risk. So we could kind of take that as a given. Okay, so this page just gives you the Federal Register notice. There's both a notice, which is about 17 or so pages long, and then there's the actual draft guidance. You could find links to both of them on the main page of the OHRP website, or certainly for the near future, it will link you to some other web page we have. There's 60 days to comment. There is the end date, December 23rd. And there will be directions in those documents about how you could comment. It's very, very easy. You could do it all online. So, and we genuinely are looking forward to seeing what people say about this. The issue certainly has gotten a lot of attention, and we kind of want to go forward in an appropriate way in terms of this. So do, if you have any interest in any of this, feel free to comment. Okay. These are the four main topics in the draft guidance document. What are standards of care? What are risks of research? When is evaluating a risk considered a purpose of the research? And are the risks of the research associated with the purpose of the studies of standards of care reasonably foreseeable risks? In terms of what I'm going to go through, I'm not going to so much go through all the issues in the guidance and all the points listed here, but I want to give you major themes in terms of what the guidance is what the draft guidance is trying to do. But just be aware these are the four topics in the guidance. Okay, so let me start out with, put this in context. What's really at stake here? Because a lot of people were spending a lot of time debating this in a very public manner. And from our viewpoint, the biggest issue here is you're trying to enroll somebody, you're inviting somebody to participate in a research study, and the question is, what should you be telling them? And in terms of what you're going to tell them, the biggest issue, I would suggest, is what does it mean to tell somebody that participating in a study involves minimal risk? And this is one of the big debates about support, because the people who criticized OHRP for finding problems with the consent forms, some of the consent forms in that study, many of them made a claim that when these studies basically involve, I guess I'd say, minimal risk. Some of them said almost no risk. That was a major theme a lot of people, pushed. And what they were basically saying was, it is in the nature of a study where both arms are a version of standard of care that randomizing, inviting somebody to participate and randomizing between two things that are both standard of care, that, you have this medical problem, some doctor could have provided that to you in terms of that treatment. By definition or by logic, you should somehow conclude this is a minimal risk study. And I'll try to demonstrate why that is not correct. But so that's why the starting point is, let's assume you're telling somebody in the consent form that, by the way, participating in the study involves minimal risk. What message does that send? And based on that message, should we care about it? Here's what the sort of what I think this message says. Different versions of it. It doesn't matter much whether or not I enter this study. Nothing important to me will turn on whether or not I participate in this study. There's no need for me to think hard about whether or not to be in this study. I think these are the general themes, okay? Often a study that's minimal risk, to give you an example, you're doing a blood draw from somebody. You're going to take the blood and do some test in the lab. The test in the lab has nothing to do with the person's health. You're not getting the results. You just need some blood, okay? So in terms of the person, the risk to them is that they're going to get a needle stuck in their arm. It's going to be painful for a minute or two. It may bleed a little bit. They're going to have a Band-Aid on it, that sort of thing. It's a minimal risk thing. The person decides, gee, am I willing to give up the half hour of my time or whatever it is to help the researchers? Okay. But again, it's like deciding to be in this study or not is not going to have a huge impact in terms of my life. And again, I think that's the theme the message you're sending when you have language in one of these consent forms that says something like that. And that is the language that some people are saying should be appropriate for these consent forms. if, in fact, you believe the conclusion that, gee, these indeed are minimal risk studies. And our point is, no, they are not. So, in fact, yeah, none of these conclusions should be true of the studies that we're talking about. And since these conclusions are not true, we shouldn't be providing them inappropriate information, telling them that these studies are minimal risk, when that may lead these people to incorrect conclusions, namely, it may cause them to enroll in a study and have something happen to them that, had they truly known what's at issue, they wouldn't have wanted to do that. And I'll be sort of explaining that. So in terms of explaining that, let me put out what I think are some myths, or at least some people, believe these things to be true in the conclusions that what was involved in, or what are involved in these types of studies, that they are minimal risk. And I want to talk about standard of care, because that seems to be the big debate, that it's sort of the moment you have standard of care, this tells you a lot about the risks in these studies. So let's assume there are two different standard of care treatments for medical problems, that they have risks that are the same type. That's just not true. I mean, you can come up with lots and lots of examples, okay? There's nothing indicating that the risks from two different treatments that are standard of care for a medical problem have to be of the same type. Same concept, two different standard of care treatments for medical problem necessarily have risks that are the same magnitude. No, it just doesn't follow. Again, remember getting back to this concept. There's this vague standard of care concept, and it's basically a generous concept that allows physicians a fair amount of leeway in terms of determining which sort of treatments they think are appropriate for medical problems. But it doesn't mean that different versions have the same types of risk, have the same type magnitude of risks. And third, similar, related point, is there any cap on how different? Okay, we have standard of care treatment A, standard of care treatment B. Let's look at the difference in terms of the risks. And is there some sort of cap in the difference between those two risks? And there isn't. Okay? I mean, one of them could sort of increase your risk of dying, and the other could not do anything to your risk of dying. This is just in the nature of differences in standard of care. I mean, this is sort of a non-issue in the area. Whatever the standards of care are, they are, but none of these things are true. That you're comparing two versions of standard of care, there could be very substantial differences in terms of the actual risks, the nature of those risks, the magnitude of those risks, and there is no cap on it. I'm just contrasting that. For example, the current rules have a number of provisions that relate to, well, if a study involves, risks that are minimal or lower, you could do certain things, for example, to children. We don't know that the differences between the two arms of one of these studies are minimal. So, and I basically tell you this, there are often substantially different risks from different versions of standard of care. And sort of summing it up, choosing which version of standard of care to receive. Remember I was talking about sort of, you've just been told that something is not something you should worry about or care about. Well, actually, depending on your medical problem, choosing which version of standard of care you want to receive can often be one of the most important decisions you're going to make. Okay, again, which gets back to the fact that just because two things are both standard of care for the same disease, it tells you almost nothing about the relationship of the risks of the two things. Now, this is not to say that in a particular scenario there may be minimal risk differences, but that's fact dependent. And so let me just show you an example, because there's a lot of sort of theoretical discussion. This is from a real consent form that is from an ongoing study. This is a study in which people are randomized. These people with a disease that, if not treated correctly, they can die of this disease in a few years. And this is from the risk section. Because both of these treatment approaches are considered to be standard of care, participation in this study is considered to cause you minimal risk. And then it goes on, the only risk to those who take part in this study is the potential loss of privacy if you choose to share your condition through online social media. Okay? A real consent form, people who have a serious disease, and you're randomizing between two different ways to treat that disease, and this is what the consent form says. So I can give you the context of what we're actually talking about in terms of what we should be telling subjects. You know nothing, Jon Snow. Some of you, for those of you who this is from Game of Thrones on HBO. I'm sure a lot of, husbands are aware. My wife often tells me I know nothing, with good cause for doing that. But anyhow, I love the show and I love the books, and I really do think this embodies an important concept here, because as I'm going to discuss, a major theme in the discussion here is how little we know about medical treatments. And there's a lot of things we actually don't know a lot about, but there's a point where we actually do know something, and that we're going overboard in terms of arguing that how little we know and therefore we can't decide anything. And so I've called this radical knowledge denial, that basically this is an extreme view of we know nothing, Jon Snow. And so this is stating the myth. In almost all studies involving comparisons of standard of care, we know nothing about possible differences in risks. Again, this is the extreme view of it, but I think some people are sort of saying this. You know, here's the disease, different treatments out there. We know nothing about how treatment A differs from treatment B in terms of the risks. We're 100% clueless. I'll give you different versions of this. Until a risk is absolutely 100% understood and proven, it is unnecessary for researchers to disclose it to potential subjects, because we're not sure yet. We don't know if this risk is really real or not, so we don't tell them about it. Another way of stating this, or a little variant version of it, where risks are uncertain, it really makes no difference whether a patient is randomized in a study or a doctor chooses which version of standard of care to provide. Both are equally arbitrary. So notice they're analogizing a doctor making a decision about which version of standard of care to treat you with versus this researcher who's randomizing you. And there may be scenarios in which this is appropriate, where we really do know nothing and doctors are just basically flipping a coin. But there are numerous scenarios in which we actually have some tentative information. And I guess that's what I say here. The truth is that people make decisions using tentative information all the time. That is a part of everyday life. It has always been the core concept of informed consent in research. You know, it's sort of ironic here, because by definition, in research studies, there is uncertainty. That's why we do research. We're actually trying to resolve uncertainty. And what we often have to tell subjects about is, look, this is what we're worried about. We're worried about this risk. Are you willing to expose yourself to that risk? And so let me give you an example. This is sort of a personal example, but that's why I sort of thought about it. I know some of you are aware I missed a SACHART meeting, I guess last March, right? Not that long ago, because I underwent heart repair, open heart surgery to repair my mitral valve. And I ended up getting, they cut your sternum, not the whole sternum, but the middle of the sternum, and then they pry it open and they go in and fix the valve. From my viewpoint, it was sort of a big deal, and you went through a lot of thinking to figure out were you doing the right thing. So let's assume, okay, talk to the doctor, he's telling me that's the surgery he's going to do and all that sort of good stuff. And then a week before the surgery, he hands me, and this is sort of hypothetical, but I don't think it's totally off the wall. He hands me a consent form and saying, you know, there's been some dispute out there about the best way to actually do this type of surgery. And so instead of cutting the middle of your sternum and prying it apart, some doctors are going between the ribs on the right side. And that way they don't have to break any bones and that sort of thing. And actually we can use a smaller cut than we do in terms of the breastbone. So I'm proposing to enroll you in this study in which we're going to randomize people between cutting the sternum versus going between the ribs. And what I will tell you, which is totally correct, and you can check this on the web all over the place, both versions I told you about are totally standard of care. You could go to the Cleveland Clinic, which is the preeminent place to, I thought of going there too, preeminent place to go for heart valve repairs. They point out they do more than 1,000 a year, and they will discuss all of these things are ways to do your surgery, and these are all options, and they will tell you all about it. There's a lot of promotion in a lot of places, particularly about between the ribs, because a lot of people view that as sort of less invasive than cutting the breastbone, although there's disputes about what is or is not minimally invasive. Some will say cutting the breastbone, if you use a small cut, is also minimally invasive. But anyhow, so they're proposing this study to me, and I look through the literature, and you actually figure out there's genuine uncertainty in terms of these two ways of doing it, in terms of which is better, and there are specific risks they're thinking about. If you go between the ribs, it's more complicated. They have to stop your heart and you're not breathing and put you on heart-lung bypass. And that's a complicated thing to do if you don't have direct access to the heart and the blood vessels going into it. So they have to do it a more complicated way if they go between the ribs. And there's some thinking out there, some bit of evidence, or there's some, some thinking, guessing that maybe there's a greater risk of you having a stroke if you undergo that. On the other hand, if you get through the breastbone, could be you're going to be in the hospital, a few more days, and that's not necessarily a good thing for you, whatever it is. So bottom line, there's some risks on one side, some risks on the other side. And so the question is, this would meet the standards that some people said. This is a study randomizing you between two different versions of standard of care. I have to say, personally, making that decision, I would have thought it was a big deal. In fact, even not in the study, making the decision was a big deal. So saying in the consent form, which is the main document, which is to let you know what's going on and letting you decide, do I want to be in this study or not, saying in that consent form, gee, this is a minimal risk study. The biggest risk to you is, you might actually tell somebody you actually have a heart problem or something and you might get fired, whatever it is. I would think that's inappropriate. I mean, this study involves more than minimal risk because there are more than minimal risk differences between the two arms. So, but I'm just giving that as an example, getting away from dying babies. And so let me just, as a final example here, say a little bit about support, because again, this sort of triggered all this discussion. And as I noted before, one of the major concerns in support was figuring out the right oxygen level to minimize this bad eye problem, retinopathy of prematurity. And in general, it was thought that the higher oxygen level you go to, remember I said 85 to 95 was the range, you get closer to 95, the concern was that you're going to have more of the retinopathy. There was also a concern, but this is a disputed point, on the low end about some other risks, because if you're not giving enough oxygen, maybe the infant might actually have an increase in they might be more likely to die, and they might actually develop some brain damage. And this, I just want to indicate, OHRP has indicated this before, there are multiple statements from the people who did the study. In fact, the support study was one of 5 studies done around the world. The other 4, the name for most of them was different. It was BOOST. And they were designed together so that you could put all the results together because they knew you needed a lot of subjects to actually have the statistics work out. And I have a number of slides here that just demonstrate that even before the support study started, that's what this one is saying, they were worrying about mortality and disability. They were worried about a problem at the low end. This was the United Kingdom protocol, and again, it talks about, restricting oxygen risks increasing early mortality, increasing the number of survivors with cerebral palsy, brain damage, and reducing cognitive ability. The Cochrane collaboration. Some of you are familiar with Cochrane collaboration reports, supposed to be unbiased reports that basically survey the general thinking in an area. And in fact, this particular report was about this issue of how do we figure out the right oxygen level, and it was looking in particular about how does that relate to a perhaps increased risk of death. And Dr. Askey, who was the lead author on this, actually happened to be the person who was the person in charge of coordinating the 5 studies and putting the data all together. And this came out during the support study while it was still taking place. And it was noting that some people were highlighting, hey, there are a few recent studies that didn't demonstrate an increased risk of death. And look, regardless of that, we still have uncertainty at the low oxygen end, and they specifically say that here. Those studies lacked adequate statistical power to exclude small but important increase in death and disability. And currently, so they noted, again, she was in charge of this study. There are 5 ongoing randomized trials being conducted. That was basically support and the 4 other versions in 4 other countries. And the results from those are going to be combined to resolve that question about whether or not there's an increased risk of death or disability. So, I mean, the bottom line was this was a difficult decision, what oxygen level to put an infant at. If you go too low, there were certain risks they're worried about. If you go too high, there are different risks, blindness, whatever it is. And this was an important study designed to find out about. The only question is, what do our current ethical rules require in terms of letting people know what it meant to enroll your child in this study? And this was just from the BOOST consent form in New Zealand. The aim of the study is to determine if use of low oxygen levels is safe and effective in reducing serious vision and lung problems without increasing mortality or neurodevelopmental disability. And finally, the last two slides, and then I'm done with the low oxygen discussion here. This is from the actual printed, published results in the New England Journal from the support study. This is on the first page from the abstract from the background. This is what they said about the background. It is unclear what range of oxygen saturation is appropriate to minimize retinopathy without increasing adverse outcomes. And a page later, they actually discuss prior studies noting, criticizing them, that they didn't collect data about mortality and neurodevelopmental outcomes. Thus, the safety of low target levels of oxygen saturation remains a concern. So just to point out, if you end up in further discussions of the support study. But let me just close with one other point about support, because again, I do think this emphasizes this main theme. Are there different risks in terms of the different arms? And these are very crude, drawings, okay? So don't take them in terms of scale or that sort of stuff. They're just trying to demonstrate sort of a vaguely normal distribution. According to the Duke consent form, prior to support, the goal in many studies, in many medical centers, was to actually keep the infants near the middle of the acceptable range. And you can see why that might be reasonable. If you're concerned about risks at the high end in terms of blindness and risks at the low end in terms of not enough oxygen, maybe you try to keep them in the middle. So this is what might have been the treatment infants were getting at some of these medical centers prior to enrolling them in support. This was the oxygen distribution goal in the support study. Assuming the researchers achieved what they wanted to do, they wanted half the infants in the 85 to 89%, what they would call the lower oxygen range, and half in the 91 to 95% range, the higher oxygen range. They didn't end up actually getting that, but let's assume they actually were able to get what they wanted to do. And this is just, superimposing the starting point on the other, what happens in the study where you were randomized 50-50 to lower or higher. There's some degree of overlap, and again, this is not to scale. Those green areas could be much, much larger. But so the question I want to pose is, I want to eliminate areas that we have factual disputes about. Let's assume there was no concern at the low oxygen end, because some people have said that, right? Nobody was thinking at all about a possible increased risk of death or a possibly increased risk of brain damage, okay? The only thing they wanted to figure out was what oxygen level do we use to minimize, to best minimize the risk of retinopathy of prematurity. Let's look again at what happened to infants in the study. In those centers, they would have started out in this sort of yellow area in the middle. Half of them would be randomized to the red area. And remember, the position of a fair number of critics out there was that this consent form should have appropriately said, well, in fact, it sort of did say this, there are essentially almost no risks in this study. And the question is, remember, the one point pretty much everybody agreed on was that we thought there was a greater risk of retinopathy at the higher end of the scale. So if, in fact, you did believe that, you're not sure exactly what the curve looks like and what breakpoints are, et cetera, why isn't it some possibly risky to those infants who get randomized to the higher end? You'd think there'd be a risk that you've actually increased their likelihood of getting the retinopathy of prematurity. So, and again, nothing new in terms of ethical principles or your reading of the regulations. So it's a version of the standard care. That's fine. And the other thing I would point out is, by the way, it's well understood, during this time period, the move was to lower and lower oxygen levels. That was the general clinical direction that the clinical community was going in. And so notice, you would take the infants who were, like, again, between 88 and 92, and a lot of them, half of them, would be randomized to a higher oxygen level. And it would be interesting to actually look at what's happening in those centers pre-support. How many of them were taking infants and moving them to higher levels for some other reason? It just doesn't sound as if that actually makes sense in terms of what's good for those infants, assuming you were saying there were no risk at the lower end. So again, getting rid of the debated controversial aspect of that study, presumably you should have been telling the parents, there is a risk here, okay? Your infant might be, randomized to the high end. That might increase the risk of blindness. So this is just summarizing it. Randomizing people to different versions of standard care often involves changing the risks to which they may be exposed, and if informed consent is to be meaningful, we should generally be letting them know about these changed risks. Now, this is another part of the debate that some people are talking about. The guidance was based on the core ethical principles that are embodied in our current regulations. And I think some people have said that if you disclose risks in this way, you're going to discourage people from enrolling in research. And that raises the question, well, okay, do you want to change the regulations? That is a very different conversation. What we were trying to do was our society, the government for our society, currently has certain ethical principles embodied in the common rule, and our draft guidance is our interpretation of what those rules have always said and just applying it to this fact pattern. And I think that took me too long. I apologize. So I guess I could sit down there or whatever.
Thank you. I'd like to apologize for two things. One is obviously the quality of the sound, which made that even harder to listen to. The second is that we in no way want people to come away with the impression that the IOM or the Planning Committee is taking a position on the support study, nor are we showing Jerry Menikoff's description of his critique of the support study in order to give greater play to that. It's simply that we wanted a chance for people to hear the OHRP thinking behind the guidance, and unfortunately the discussion of the support study and the guidance seemed to be interspersed enough that it was difficult to edit that down. So I do want to apologize if we're giving any impression of having a position on this. And I can't emphasize enough that this is not about the support study, but about everything else. So with that, just a couple of final remarks before we get going. First, I'd like to take a moment to simply introduce the members of the Planning Committee. Whoops. There they are. And if you guys can just raise your hands just so that people know where you're sitting. Okay, we've got Celia Fisher from Fordham, Steve Hyman from the Broad Institute at Harvard and MIT, Clay Johnson. Where's Clay? Oh, back there. Wow. Okay. There's Clay from the University of Texas, Austin, Greg Simon over here in the front row from the Group Health Research Institute, and Marjorie Spears over here in the front from Spears Research Strategies. And I'd like to thank all of them for many, many hours on conference calls trying to figure out what to do here. So just as a quick, I'm going backwards, I'm sorry. This is the effect of having a cold. You know, your brain goes backwards. So just as a reminder, certain meeting objectives to consider how the risks associated with standard of care interventions might or might not be distinguishable from the risks of those clinical care interventions, the criteria for figuring out which ones are reasonably foreseeable and those that aren't, and how to describe those to the various participants. The draft guidance that was referred to is available for commenting until toward the end of December, and this is the website for that. And of course, you can easily find that just by Googling online. Before we get to our first panel, just one last set of housekeeping items. First, in the realm of confession, people like me and some of you are no longer supposed to be stealing food from other events that are going on in the building. We've been chastised. So please, there's a cafeteria that is downstairs where you can get refreshments. We don't have in our budget enough to provide them for you. Apparently the other meetings are wealthier than ours. Other housekeeping notes. There's going to be a morning break at 10:25 and lunch at 12:30. Again, you'll need to go to the cafeteria. Sheena, can you tell people how to find the cafeteria?
Walking through the atrium by the Christmas tree. Make it
Each panel will conclude with 20 minutes set aside for comments and discussion from the audience for people who have pre-registered. Please note that the whole meeting is being webcast, so you are online right now. There's a Twitter hashtag of hashtag IOM Standard of Care, and there'll be a slide rotating that has the hashtag. If you are from the audience and you're making comments, please use the microphones on either side, or we'll have a handheld that's going around. For our panelists, please turn off your mics when you're not speaking and turn them on when you are. All the slides that you see today will be available in about a week on the IOM website. Speaker biographies are sitting outside in the handouts if you haven't gotten them already. And just so that I can conclude my semester with my final class, Steve Hyman will be taking over the chairing duties for tomorrow. There will be no break tomorrow morning, but this meeting will conclude by about 12:30. So with that, I'd like to invite our first panel to please come up. We've got Greg Simon and Steve Hyman moderating on randomization of participants.